All right. Okay, well, aloha, everybody. My name is Jeanette Kojane. I'm the Executive Director of Kōkua Mau, and I'm so glad everybody's joining us today. We have an amazing panel of experts here in our community. So I really wanted to thank everybody who's speaking today. We have an amazing panel. And what I'm going to do is just give some brief bios at the beginning, and then and then at the end, there will be time for questions. Our first speaker will be Dr. Emese Somogyi, which I think many of you know. She's a palliative care physician with 25 years of clinical experience and has been practicing in Hawaii for more than 20 of those years. She is an associate clinical professor at JABSOM and a long-standing board member of Kōkua Mau. Thank you very much, Emese. And she is newly employed by the VA along with Dr. Katie Melton to expand palliative care services for veterans. So our second speaker is Dr. Lavonda Nakamoto. She is a 99 JABSOM graduate and completed her internal medical residency in 2002 and had a 2-year geriatric fellowship in 2004. She worked as an assistant professor at UH, Department of Geriatrics, and then she joined the VA full-time in 2008 as the home-based primary care medical director. So currently she's the chief of home care programs in the VA, geriatrics, rehab, and extended care. And she enjoys teaching, seeing geriatric patients in the clinic, doing home visits, and administrative work. I think she's the only one who admits to that. Erin Hamilton is a senior area director for Bristol, Hawaii. She began her healthcare career 14 years ago with a focus on genetic and biopharmacy at UH up in Manoa, and began working in hospice 8 years ago. She is currently the state chair for hospice and palliative services and a founder of Caregiver Connection of Hawaii, a free online public database for healthcare navigation. I also, the other people on the team, Dr. Katie Melton finished her hospice and palliative medicine fellowship at the University of Iowa in 2019. And since then, she's worked both inpatient and outpatient. She is excited to be joining Dr. Somogyi at the VA to help expand palliative care services. And in the near future, she will be assisting with palliative care consultations for adult inpatient at Tripler. So that's also very good. We can ask Katie about that. And the final part of the team in the background is the amazing Amanda Wong, who is an APRN up at the VA Pacific Healthcare System, and she is the hospice and palliative care coordinator. And just two more people, shout out to Joseph Epinick at Bristol, as well as Savannah, who have really been helping with pulling all of this together today for the We Honor Veterans. So I'm going to stop talking now and turn it over to Dr. Emese, and then Amanda is going to share the slides. So thank you, everybody.
So good afternoon, everybody. I hope you can hear me okay. And thank you for spending a little bit of time with us. I thought I'm pretty well prepared for this presentation, but then Jeanette referred to me as an expert. So now I'm like really nervous because it's exactly 2 months ago today that I joined the VA. If you have questions, please feel free to ask. Chances are that I'll need Amanda's help answering them. Next slide, please. So a few disclosures that are important to make. First of all, that we are not specialists on VA benefits, we are clinicians, and those benefits are extremely complex and they can change. There is going to be a lot of information, yet this is still going to be just a very general overview of all the services that are available for seriously and terminally ill people at the VA. And finally, of course, the views expressed here are our own. Next slide, please. So before I dwell into this slide, I just wanted to mention that my hope is that you are going to take away two key things from this presentation. One is that the VA benefits can be really amazing, but they are not available on a short notice. And that if you have friends, clients, family members who are eligible or might want to use benefits, it requires well ahead planning. And I think it's going to be clear as we progress. Why am I emphasizing that? So when we are talking about the VA, people often have a lot of confusion. What is that exactly we are talking about? So the VA is, I heard people say, the largest integrated healthcare system perhaps in the world. The Department of Veterans Affairs has basically three big branches, and medical care, including hospice and palliative care, falls under the Veterans Health Administration. Anything that has to do with money, like compensation and pensions and so on, falls under the Veterans Benefits Administration. It's separate from health services. And finally, yet another separate branch is the National Cemetery Administration that has to do with managing veteran cemeteries. What I think is a very helpful way to think about Veterans Health Administration is that while the VA is a provider of medical care, we are also purchasers of healthcare in the community, and in particular relative to hospice and palliative care. That's very important to keep in mind. The resources are for enrolled veterans, and there will be more said about that. And to get you just the scope of what a massive organization this is, nationally, there are over 9 million veterans who are enrolled in the VA healthcare system. And this one basically is just to kind of get across the idea that we are under Veterans Health Administration. The organization is called here in the state VA Pacific Islands Healthcare System, and that hospice and palliative care falls under the geriatric rehabilitation and extended care part of the organization. I'm not going to even remotely touch on anything beyond hospice and palliative care, but we listed a few phone numbers for those who might be doing case management or work with clients if they have need to reach out and inquire about financial or burial benefits. Next slide, please. One thing is eligibility. So just because somebody somewhere served in some branch of the military doesn't necessarily mean that they are eligible for VAJ benefits. They must meet specific criteria, and they have to actively enroll in the system, which takes time. And because it's a heavy focus on primary care, they need to have a primary care physician also assigned in the system before they can start accessing other services. To make things a little bit even more complicated, there are priority groups. So not everybody is same in terms of their VAJ benefits, and there are 8 priority groups. And that's determined based on their military history, their rating of disability and income. So the highest priority, those who have some sort of a service-connected disability, which is rated at 50% or more. And the lowest is those who have no service-connected disabilities and they have high enough income that the VA is going to ask them for co-pays for services. And there is a whole range in between. A helpful tip I heard recently, and I'm going to share it here, is again for those who work with clients or case management, is that to establish service-connected disability, which really matters in serious and terminal illness, because I know from my previous life in being a palliative care provider in the community, oftentimes when people start turning towards the VA is when somebody needs long-term care, which is very, very expensive. However, to get long-term care through the VA, you have to have at least 70% service-connected disability, and establishing that service-connected disability is quite a process, and people have to be functional enough and cognitive enough to go through that process, through the assessments required. So again, plan ahead. So here is, if you're already starting to feel confused, let me add more to it. Veterans often have one or several different types of health insurance. One could be the VA, but it could be any complication of Medicare, commercial like HMSA or Kaiser or Medicaid or TRICARE. And on top of that, mishmash of insurance that they might carry. They might also have like puzzle pieces all over the place in terms of, are they getting some or all or none of their healthcare at the VA? And here is yet another layer to it. So the VA gives a choice to the veterans, and in terms of who the payer for services is going to be. So for example, the patient might decide to see a provider in the community, let's say a cardiologist, and even though they have Medicare, they might say, no, I want the VA to pay for that. They have that right. Next slide, please. So this is adding up to such a level of complexity that the VA is now developing like specific names and languages. So self-directed care or external healthcare providers is VA speak for services and providers who are paid for by the veterans non-VA health insurer. So if you have a patient whose name, let's say, is Mr. Liu, and he sees a cardiologist, Dr. Smith, in the community, and Medicare pays for it, then it's referred to as an external healthcare provider. If Mr. Liu decides that the VA should pay for the same cardiologist, Dr. Smith, then the language becomes community care and community healthcare providers. And if the VA pays for the services, that requires oversight, obviously. So there is a big branch of the VA these days that handles the authorization processes for all the purchased healthcare in the community, and they call it CITSI, which stands for Care in the Community. So again, this is going to be relevant to palliative care and hospice services. So just to tell you a little bit about our local VA, because there are a few unique things about it. For one unique thing is that it covers not only Hawaii, but Guam, also American Samoa, and some other Pacific islands. So it spreads over a huge geographic area, yet at the same time, it's one of the very few in the nation that doesn't have its own hospital. So in that way, Hawaii is very unique, though some inpatient services are available at Tripler. And again, just to give you an idea about the number of people covered, there are over 50,000 of them. Next slide, please. So finally, I'm getting to hospice and palliative care is part of this much larger entity. So the pioneers, as many of you I'm sure know, were Dr. Craig Chena, who's been with the VA. I don't know exactly how long, but all the 22 years I've been in Hawaii. And then Leanne Tokushige, who is now happily retired, and Amanda Wong, our nurse practitioner, clinical coordinator. Next slide, please. And in case some of you don't know us, this is Katie and myself. And as you can see, having red hair and blue eyes is a requirement to be a palliative care physician at the VA. So the topics I'm going to review are home hospice, inpatient hospice, VA concurrent care, palliative care, outpatient consultations, the joint venture that Katie is spearheading with Tripler to provide inpatient care. And finally, it's going to be just a little bit of a reminder about the VA and policies on medical aid in dying. So home hospice, again, going back to that insurance puzzle, if the veteran who is enrolled in the VA, they have the option to use either their VA benefit or their private insurance if they have some to cover for home hospice services. I was told that it's usually people, if they have private insurance, that's what ends up being used, because that's also what the hospices are more accustomed to, and most of a lot of referrals come from the community. But home hospice is a basic benefit for all enrolled veterans if they choose to use the VA benefit, so regardless of those priority groups or service connection. And the criteria are essentially the same as Medicare, patient with life-limiting illness. Goals are for comfort rather than cure. An estimated 6 months or less prognosis, which usually has to be certified by a VA provider if the VA is the one to cover for the services, and agreeable to hospice care. Next one. Next slide, please, Amanda. Thank you. So here is the process. And again, please pay attention to this, because oftentimes, you know, the thinking is, oh, this person wants hospice, let's call Amanda at the VA. But the referrals to the hospice agency need to come from the VA primary care physician if they are not initiated by a community provider and using the community insurance. If the patient has Medicare and they're going to use their Medicare for home hospice, then there is no involvement for us, the palliative care team. However, if the patient uses their VA benefit, either because they want to or they don't have other insurance, then we play a role, but essentially is not as clinicians, but we are the ones who provide the initial authorization and then the regular reauthorization for the services. I wanted to highlight really nice VA benefit here that can be provided in addition to home hospice, and that's a program called Homemaker Home Health Aid Services. And again, this is a pretty lengthy process, but eligible veterans can get up to 16 hours a week of Homemaker Home Health Aid Services through contracted community agencies that supplement the services of the hospice. So again, a nice benefit worth keeping in mind. We all know how extremely difficult it can be on caregivers to provide hospice in the home. Okay, inpatient hospice eligibility. So now we are going to talk about patients who are looking to have not only the hospice, but the hospice room and board covered by the VA. So again, you know, this is for those who are already registered and eligible for the VA, have a primary care physician in the VA, have to have a life-limiting illness, goals of care is comfort, but this is important, okay, because this is not we always think, oh, 6 months, no. To cover facility fees, the prognosis has to be 3 months or less. And obviously, VA concurrent care patients are excluded. So this is another part that's really important to understand, that yes, the VA can, for those patients who are deemed to have 3 months of less, can cover the facility fees, but there are some, again, a lot of structure around that. Typically, it's going to be in a VA contracted nursing home. And I just, for completeness, I listed the different nursing homes that the VA has a contract with across the islands. The other option would be the community living center, which is the place many refer to as the Center for Aging, the long-term care SNF facility on the Tripler campus, which many of you, I'm sure, remember, that used to have a dedicated hospice beds, and Dr. Craig China was in charge of that. And I 2 months ago, when I started at the VA, I was still under the happy illusion that it's still the case. And then I had to learn that with the pandemic and some changes, the community living center lost beds, and now can take hospice patients, but it's no longer dedicated beds. So there has to be an opening, and then there has to be appropriate staffing. And finally, if there is no other options, or the veteran has some really complex care needs that cannot be managed in a nursing home, the VA could authorize for going to a freestanding hospice facility that's managed by the hospice agency. I was also a little bit surprised to learn that the VA does not contract with private care homes. So whether for facility hospice or for long-term care, typically we are really looking at nursing homes. But I'm sure Lavonda can say a little bit more about that later on. So the process for the hospice referral is again something I would like to talk about a little bit, because again, until not very long ago, I was on the other end of it, referring patients from polymomia and then feeling frustrated that it took a long time. But after this, it's going to be a little bit, I think, more evident why it's such a lengthy process, and that us, the team, actually has only limited control over the progression of all this. So first of all, for these inpatient hospice referrals, the VA requires lengthy documentation. This includes the Geriatrics extended care form, which you can find online if you were ever wondering. It's a very detailed assessment form that's standardized nationally. We need recent progress notes if there's documentation of goals of care, if there's advanced healthcare directive, the person is going to require a TB clearance and a medication list. So all this gets submitted to us, and then Amanda and the rest of the team will review the whole package. But the next step in the process is that the VA has an interdisciplinary screening team that meets daily to look at all the different applications for long-term care, short-term rehab, hospice, and so on. Once that approval is received, then there is still yet another step, and that's to find a bed. And actually, I'm going to start with the bottom of this slide and go back to the issue of time. So how much time does it take to get your patient into a VA inpatient hospice bed? It depends on the time to receive documentation, and it's not unusual that it takes several days, like, oh yeah, TB clearance, that's 48 hours, and so on. Time to review, that's the only part we have control over. And then after the review and presenting to the screening committee, it's again out of our hands, because then comes the search for finding a bed in a contracted nursing home or the CLC. So again, in this process, we have a role in terms of doing the clinical review. We also have a role doing the initial authorization, and the reauthorization as well, which usually these patients get reviewed. Depends, but oftentimes it's every 30 days. And that's when you are going to get a friendly call from Amanda if you are a hospice agency, because there is a review not only of the electronic medical record, the VA record, but also the hospice's documentation. And the benefit is for 90 days. And at the 90 days, there has to be a plan for alternative disposition if the patient is still with us. My apologies for being blunt. Okay, I'm gonna switch gears now again and talk a little bit about the VA concurrent care, which some of you might remember. Dr. Leanne Takushige was very instrumental in setting up. And if I'm gonna have a takeaway message here, it's that please do not mix it up with the HMSA supportive care, because criteria are different, and it's not like people can transition easily from one to the other, even if they have both VA and HMSA benefits. The very major practical difference is that the life expectancy for supportive care, I believe, is estimated less. For VA concurrent care, it's 6 months or less. So essentially think that somebody who would meet hospice eligibility criteria but wishes to continue disease modifying treatments for their underlying condition. On the clinical side, once the veteran is enrolled, it's essentially in home support provided by the hospice agencies and paid by the VA. But again, there is a review process I'll mention, and part of that is to to make sure that there is no duplication of services, such as let's say a home health RN and the hospice RN coming to the home. Another pearl that some of you might appreciate when trying to find good solutions for your clients or patients is that there is another way to kind of get the best of both worlds. One is concurrent care, when VA pays for the hospice services and then the veteran gets their disease modifying treatments, including chemotherapy or whatever is appropriate, either through the VA or through their private insurance. Alternatively, the VA allows for patients who have private insurance, such as Medicare, to go on traditional hospice. So they enroll in a community hospice agency under their Medicare, but they access their VA benefits for disease modifying or palliative treatments. So the VA, let's say, pays for their chemotherapy or immune therapy. So there is more than one way to achieve that mix of disease modifying or life prolonging treatments and in-home support from a hospice agency. Okay, so I already emphasized the 6 months or less. The other important thing to remember is that essentially the qualifying diagnoses are stage 4 cancer, advanced heart disease, and end-stage lung disease, and adult failure to thrive or advanced dementia are actually not considered as eligible diagnosis for concurrent care with the VA. Next slide, please. Again, this is not I wish it was a really fast process to enroll people, and it's not, because another requirement is that in this situation we are both act as clinicians and is part of the authorization process. So we actually require either a face-to-face or a VA telehealth appointment to assess the patient to ensure that they meet the criteria. And if they do, then we work with the hospice agency and start the authorization process. So once the veteran is enrolled, the VA primary care team remains the primary contact for the hospice agency, and our clinical role is the VA palliative care team stops there. However, our role is the review and authorization of services continues. So the hospice agency will provide ongoing goals of care conversations, at least weekly nursing visits, other services is appropriate, transitioning to hospice is appropriate, at predetermined intervals, which means 90 days, and then after that every 60 days, we do a review of both the electronic medical record and documentation from the hospice agency. So again, this is when Amanda calls and requests the last few notes from the hospice nurses visit for our review. So almost there. I'm starting to feel like I'm running a marathon here. But just a quick reminder, and this actually came up just very recently, so I feel very confident it's relevant. VA position on medical aid in dying. So VA is a federal agency, so as such, it prohibits authorization or payment of any evaluation, facilitation, assistance, or medications related to medical aid in dying. If the veteran chooses to pursue it outside of the VA through their community, to their providers in the community, they are obviously responsible for the cost, either, through their private insurance or out of pocket. As we know, a lot of people who use medical aid in dying, they are already on hospice. And if the home hospice is paid by the VA, that's okay. The hospice services are not going to be disrupted. And finally, just a few quick words. One of the new projects that we are hoping to expand on outpatient palliative consultation services. Now that we have the luxury of 2 physicians, in addition to Amanda and Dr. China. So we would like to have more ready access to outpatient consultation services, either face-to-face or via telehealth, offer initial consultations and follow-up visits is needed. It's going to be a consultative model. That means that we will not do opioid prescribing, and all types of serious illness is referred by their VA PCP or the VA specialist. And again, the outpatient consultation service will also do the concurrent care evaluations. So the VA and Tripler decided to start on this joint venture of establishing an inpatient palliative care consultation service, which became even more urgent with the retirement of the one and only phenomenal Pat Nishimoto, who's been really doing a tremendous job serving seriously ill patients at Tripler for many decades. The idea is that it would be a VA provider, specifically Dr. Melton with me as a backup if needed, to provide consults for not only hospitalized veterans, but to all adult inpatients at Tripler. So finally, the take-home message is, if you want to find out about services, really the first step is to call the, excuse me, VA call center. That's the way you can verify if this person is registered, enrolled, and eligible for VA healthcare. And then as far as for those patients who are enrolled and registered for initiating any kind of a services, your entry is the VA primary care physician. So the request has to come from them. So the first thing to do is not to call Amanda, but the PCP. And here are the phone numbers: the call center, bolded, and our number for the palliative care team, 433-7676. I believe that's the last slide from me. I don't know, Jeanette, what you would like to do, if we'll save the questions to the end, and for now just roll over.
Why don't we do that? And
Okay.
So why don't we, Lavonda, I think, is up next, and she's going to share her slides. So thank you very much, Emese.
My pleasure.
Okay, so I just was asked to touch on some of the other geriatrics and extended care programs we have at the VA. And we're very fortunate that we have a number of programs at the VA that serve the needs of disabled and elderly veterans. Dr. Carruthers was one of the individuals who really worked hard, along with a number of other pioneers, to build up the services at the VA. And we're very fortunate that we have a number of programs which help veterans in many different ways. So I just wanted to touch on briefly on the nursing home programs. Dr. Somogyi already explained about the CLC, which is our VA, essentially our VA nursing home, which is located at Tripler campus. We also have contracts with community nursing homes. We have the State Veterans Home, which is in Hilo. And then we have another veterans home that's being built on this island, and that is targeted for completion in 2023. Some of the other programs that we have are geriatrics clinic services, and we have consultations and primary care for geriatrics patients. We also have home care programs, including our home-based primary care program, or HBPC, and hospital and home, which is, both of these programs are important programs that service the needs of individuals who have challenging medical issues. They're not all elderly, but they often will have chronic medical conditions. And home-based primary care has a full interdisciplinary team that goes into the home to service patients who tend to be failing usual care. They're failing clinic care for a number of different reasons. And so we have our nurses who serve as case managers, and then we have a full interdisciplinary team that follows the patient for the rest of their life. And we actually overlap with palliative and hospice services in the home, so that we can provide them with that continuity of care and support throughout their chronic disease illness trajectory. Hospital and home provides subacute care in the home setting for conditions such as COPD, congestive heart failure, cellulitis, and community-acquired pneumonia. They do a lot of transition care management with Tripler Army Medical Center, and really help to keep patients out of the hospital. We have some very interesting non-institutional care programs, and the idea behind these programs is that we're trying to keep patients in the community as much as possible and keep them out of institutions, out of nursing homes. The non-institutional respite care program allows informal caregivers to get respite for up to 30 days per calendar year, so that they can have those extra hours that they need. Let's say they're going to have a medical procedure or something like that, and they're the primary caregiver for the veteran. They can have a caregiver, an aide who can come in for example, 8 hours a day, and allow that informal caregiver to go out and have a medical procedure or other things that they need to do. So that's an important benefit. The Homemaker Home Health Aid Program, Dr. Somogyi already touched on, and that program is also respite for informal caregivers. And the main qualification for all of these programs is that patients have to meet the nursing home level of care designation. And there's a case mix that goes into the administration of this program, depending on the different characteristics of the patient's needs. And so patients can get anywhere from, for example, 6 to 15 hours of a home health aide coming into the home to provide services per week. The Community Adult Day Health Program are contracts with community day health facilities, and our veterans who meet the qualification of nursing home level of care are eligible for this program. And then we have the Veteran Directed Home and Community-Based Services. This provides veterans at risk for nursing home placement the opportunity to manage a monthly budget to directly hire workers and or purchase goods and services to meet their needs in a home environment and avoid nursing home placement. So this is another very important program that helps the informal caregiver to get a little bit of payment for doing that informal caregiving. The one thing to note about these non-institutional care programs is that you can't have more than one. So you do have to meet the criteria of being nursing home level of care, but then you need to choose one of them. And I mean Homemaker, Home Health Aid, CADH, or Veteran VDHCBS. And you'll find that when you work with us at the VA that we love acronyms. It's just one of our favorite things. And so sometimes if you talk to one of us, we may spew off acronyms, not even realizing that we're doing it. So don't hesitate to ask, to stop and say, hey, what does that stand for? Because we do a lot of acronym speak, so forgive us for that. The other one that I really wanted to touch on was a medical foster home program. And Dr. Somogyi was alluding to or discussing different supports for individuals who are at the end of life. The medical foster home program is a wonderful program that patients do, again, have to meet nursing home level of care for this program. But the nice thing is that home-based primary care, our home care program, provides the case management for this program so that individuals, although they do have to pay for room and board, they do not have to pay for a case management fee. And the good thing is that if a patient does come to the end of life needing palliative or hospice services, they can receive that in conjunction with the medical foster home care. We do have some other supportive programs such as spinal cord injury, rehabilitation, acupuncture, and other rehabilitation programs under GREC. So that's a quick summary of what I wanted to discuss with you today. And I do have a handout that, that can be shared with you. So thank you for giving me the chance to talk with you today.
Thank you, Lavonda. This is Jeanette again. If for anybody that wants a copy of Lavonda's handout, you can send Hope or I your email or send us a note in the chat, and we can be sure to send that via email later on. And the very informative 2-page handout, which uses lots of acronyms, but also very nice description of all of these programs. And this is geared at professionals. We don't want, they ask that it doesn't go out to the clients, but rather for professionals.
One more thing, Jeanette, maybe if I can just pipe in another program that applies to this seriously ill population is called Home Telehealth, and which is basically in-home monitoring of vital signs and so on. And one reason I wanted to mention it is, even though it's not under the geriatric service line, the person in charge is another longtime friend of the hospice and palliative care community, Anna Zier. So just to prove that palliative care providers don't die, they get recycled.
And what is the name of her program?
Home Telehealth.
Home Telehealth. Okay, great.
Yes. So it's, putting a gadget into the home that helps with monitoring blood pressures, vital signs, regular communication with the program staff.
Katie, do you want to say anything about what might be happening up at Tripler, and then we'll pass the baton on to Erin?
Yeah, I wish I had something a little more concrete to tell you, but it is still very much in its infancy stages. Continuing to jump through some hoops to try to get everything figured out. But essentially what Emese highlighted is that my role will be to provide inpatient palliative care consultations, not only to the veterans, but any adult inpatient at Tripler. So trying to pick up from where Pat left off, because I know that Tripler in many ways, shapes, and forms has really been hurting since she retired. And so everyone is anxiously awaiting all parties coming to agreement so that I can go ahead and get started, including myself. I'm very excited to just see where this goes and enhance the education of all of the residents and medical students that visit Tripler. I think it's really exciting.
Well, fabulous. Thank you. And isn't it nice that people recognize how wonderful Pat Nishimoto is? So good. Well, thank you. People are putting some questions in the chat room, but I think what we should do is have Erin do the final slides, and then we can go back. So people should put their questions. So Erin, you can share your slides. And then if people have other questions, they can put them in the chat, or I can call on people. And then for those who are asking us for copies of the slides and the handouts, you can send a private email to Hope or I with your email, and then we'll forward that along. Okay. So Erin, you are up next.
All right. I promise I will be quick, but I'm here today to kind of just follow up on the piece about the hospice organization and what that process looks like, and segment mainly into three main parts, which will be the community messaging, the intake, the referral process and navigation, as well as the admission and ongoing assessments and some tools that might be helpful quickly. So we're going to do the simple version, and that's going to be the community education piece. So for the community education piece, as everyone can tell, there is a lot of information out there. There's a lot of resources. So we were really just trying to look at how can we simplify this message, being that Hawaii is also a very unique program. We have patients that are going to be multiply insured. So they may be a veteran, they may also have HMSA, they may have many insurance and many different scenarios. So we're also going for our We Honor Veterans level 5. And so through that process of getting that certification, we have come to understand a lot and also have a lot more questions. So hopefully we can shed a little bit more clarity for you. So the more complicated version would be, this is pretty much that solar flare, but of your brain. And this is what it's going to be looking like for us on our side. So the simplified version that we are reaching out to the community is, are you a registered veteran that is either seeking curative treatments or not seeking curative treatments? And then what we do from there, this is kind of our algorithm and our mind map. So we would be receiving the referral, and sometimes we're going to get the referral from the VA, sometimes we're going to get it from a hospital or a caregiver or a family member, and it's going to directly go straight into our intake department. We're going to do a benefit check. We're going to check to see if maybe they're going to be eligible for concurrent care, if they have a private insurance, if they're a veteran, if they have Medicare. And then also checking to see if they do want to utilize their VA benefits, if they're registered as well. And as mentioned by Dr. Emese, hospice can use the VA, Medicare, Medicaid, or private insurance combination. And we'll get a little bit more into that later on as we go down the mind map. And after we do our insurance benefit check so that we know what resources are going to be available to the individual, we're going to be obviously checking to see what the goals are, if it's going to be the palliative route or if it's going to be the hospice route, and then what programs are available to them. So as mentioned, we have, of course, the veteran concurrent care, but we also have the HMSA, Medicare, Medicaid, and other insurance involved. If the patient is not pursuing hospice, or if they are going the palliative route, we would look into seeing if they are eligible for the VA. And as mentioned, they need to be a registered veteran. They need to have a primary care team evaluation. If they are not a registered veteran or concurrent care maybe isn't that scenario that they're going to be looking at, if they don't have those 3 C's that we were looking at, the cancer, the CHF, the COPD, we're going to be looking at private insurance. So if they have HMSA or they have another, if they are Medicare, we can also look to see if they are getting any sort of palliative treatments. They're at Tripler, let's say they're getting palliative radiation, they can utilize their hospice benefit with Medicare or their private insurance, and then they can utilize the VA to do their palliative treatments there. And if under all of those tiers, we still do not have a program available for them, then we would also be using our Bristol AIM program, which is going to be more outpatient. And then if we're looking at hospice, that's going to be our traditional situation. Typically, a person is not pursuing treatments and they have that 6-month prognosis. And then, as mentioned earlier, if they do need an inpatient bed, if they do want to use their VA benefit, as mentioned, that's going to be looking more at a 3 months prognosis. And then we would have to, of course, touch base with the CLC if that's an option. Looking at the room and board coverage, again, there's so many variables involved. So we really just want to make sure that when we first get that referral, that we are just doing everything we possibly can to see what are our options. And then in the process of doing our We Honor Veterans level 5, we have gotten a lot of resources and a lot of tools. So some of the tools that we're using is the military history checklist upon admission. So that's going to be, again, screening if they are a registered veteran, what time era did they serve in, if they were in a particular branch, the Army, the Navy, Air Force, if they served in a particular war or an era. The We Honor Veterans program is going to have certain medical diagnoses or whether it's psychological or spiritual or physical associations with each one. So it allows us to categorize that and then come up with better screening tools and make those IDT reports and approaches a little bit different for that individual. Some of the other screening tools would be the trauma-informed care, the delayed reaction to trauma worksheets, again, looking at the individualized veteran and that era that they served, and then spiritual history tools, and then some additional, the 7 C's or the stress first aid model, which was also developed in a military setting. So these are just a tiny pinch of some of the things that are offered. The We Honor Veterans program is part of the NHPCO. So any hospice can start to be in that process if they would like to, and it starts at that level 1 of that 1-star, and then the highest currently right now is a level 5. And that is it for me. Thank you.
Okay, great. Thank you very much, Erin, and thank you to our presenters. We are gonna go, and there's a bunch of questions. So I'm gonna go back to the top up here and start asking some questions. So Anita Jewell had the first question. Anita, do you want to ask it yourself or you want me to?
I'm not sure I remember everything I asked.
Well, no, and I said to Anita, I don't know exactly what all these abbreviations mean. So maybe we need a clinician to say, if a patient has a prognosis of less than 3 months.
Oh, due to cancer.
Oh, due to cancer. Okay, good.
Has end-stage renal disease with hemodialysis 3 times a week. So it's because I'm a little confused about the traditional hospice eligibility and the concurrent care eligibility. So if this patient, so they're end of life, less than 3 months because they have cancer, but they also have renal disease on dialysis and they want to continue dialysis. So does that put that patient in traditional hospice or concurrent care, or they have an option, both?
I would say depends on what kind of an insurance mix they have. So if, so for example, the patient could be on traditional hospice for their advanced cancer, but want to continue dialysis, and they can use their VA benefit to do so. That would be one possible scenario.
Yeah, and I think as far as whether or not they would be concurrent care eligible, I think there's a lot of potential variables. So it's possible, but it would have to be discussed on a case by case basis because we would just have to, like verify what exactly are the palliative treatments that they're getting for their cancer and that sort of thing. So I can't give like a definitive yes or no, but possibly it depends.
So what's the best way to figure that out then?
I think our team would need to be made aware of it. And then we, if some records are needed or if we're able to look up everything on our side ourselves, and then we would discuss amongst ourselves.
Okay, good. Because Anita helps physicians figure this out over at PMAG. So that's a good answer. Thank you very much.
May I call on Amanda to answer that question? So that it's answered to her satisfaction. Amanda?
No, this is Amanda. I agree with what Dr. Somogyi and Dr. Melton said. So I think it needs to be further discussed and reviewed. So.
Okay, good. So Katie asks a question that I know a number of people had, and those are, what are services available on the neighbor islands? And then also, are you doing consultations in the Yukio Ukutsu Veterans Home in Hilo? So those are two separate questions. So first of all, for the neighbor islands, so I'm not sure who will answer that.
Yeah, the VA Pacific Islands healthcare system involves the Hawaiian Islands as well as Guam and American Samoa. So theoretically, veterans in any of our Pacific Island network are eligible for any of the healthcare benefits. It's just a matter of availability. So, yeah, I don't know if the person is asking specifically about hospice and palliative benefits. I would defer that to the hospice palliative team. But with respect to other programs, we do have those other GREC programs available for the most part on the neighbor islands. With respect to the veterans home, that actually the VA pays a per diem for care for veterans at the state veterans home. So the actual clinical care is not provided by any VA healthcare providers. It's provided by contracted healthcare providers. So generally speaking, no, there's no direct VA consultation or care provided to the veterans in the veteran state veterans home.
So if someone is on a neighbor island or is trying to help a client on the neighbor island, what's the best way to figure out what would be available for them? So they can, if I understood you right, you can contact the hospice to figure out what they provide.
Right. If a patient is enrolled in veterans healthcare, then everything goes through the veterans primary care PAC team. So even if a patient is is co-managed with a private provider in the community, if they're enrolled in the VHA, then they are assigned a VA healthcare provider, and that's what we call a PACT team, primary care, patient care. Sorry, it's basically their primary care team. So the main thing to do would be to get that patient assigned a primary care provider, and then all the referrals would go through the primary care provider. So on the neighbor islands, we have what's called CBOCs. They're community-based outpatient clinics. And so there are primary care providers on the different neighbor islands with the VA. And so veterans on the neighbor islands could be assigned to one of those primary care providers and the CBOC. So just calling that 1-800 number, which were on the slides for the VA, would be a way to find that out.
Okay, thank you. So on the slide, when you listed the contracted nursing homes, the one in Hilo wasn't listed, but you said that that is an option for people.
The state veterans home and Hilo, yes, that's an option for individuals. Yeah.
Okay, great. Thank you very much. So just seeing Alan Gamble has a, go ahead, Emese.
So my understanding is that that's different. So that the contract nursing homes and state homes are different entities. I think that's what created the confusion.
Yes. Yeah. The state veterans home is not a contracted nursing home. It's different criteria for admission to the state veterans home.
Alan Gamble asks, would our panel please share the criteria for nursing level of care? In other words, ICF or SNF level of care, do they need to be homebound? This would be helpful for all of us.
Right. So the nursing home level of care basically is defined in the VA as having 3 ADL dependencies. That's just the quick and dirty. I mean, it's a program that goes through, there are administrators of the different programs, and so they go through a fairly lengthy process doing chart reviews, etc. But the quick and dirty is they need to have 3 activity of daily living dependencies.
Okay, good. And then a further question, how can families request a referral to a social worker or care coordinator from the VA primary care provider to sort out what might be available for a veteran and family? Is this an automatic referral?
With respect to the primary care, the veteran and the family could have to request a social work consultation. It's not automatic. So they would request an appointment with their primary care provider and then explain the situation and the needs. And then at that point, the primary care provider could consult with the social worker, who then can help facilitate referral to appropriate programs.
Okay, so it sounds like that PCP is a key gatekeeper for getting these services.
Correct.
Okay,
I hope that answers the question.
I hope so too. Alan can either raise his hand or put more questions in. And Katie, who I'm assuming is on the Big Island, is also saying is wondering how they can get a contracted nursing home. So I don't know if you guys have any suggestions for her, but.
I just wanted to make a quick comment. I think of the primary care physician more as a gate opener in the VA than a gatekeeper.
Oh, good. Okay, excellent. Good point.
Because, it's just, that part of the path that you have to walk down to get to the services that you want or need.
How about a crucial part of figuring all this out is this PCP?
Yes.
Okay, yeah. And Katie's suggestion is to have educational seminars with outpatient clinical social workers, because she and her husband are both veterans and find this very confusing. So there's a concrete suggestion there. And Pat Nishimoto says at the VA Center on Oahu, each PCP is located in a module and each module has a social worker. And she doesn't know how the outer island, how the neighbor islands are structured, but that's what happens here on Oahu.
Yeah, thanks, Dr. Nishimoto. Yes, that's correct. And there are social workers at the community-based outpatient clinics on the neighbor islands as well, that service each of the primary care teams. With respect to Ms. Kasoro's comment, yeah, I agree with you. It is confusing. The system is confusing. And I am not an expert on, for example, the state veterans home. But I would say that, a lot of our veterans who would be appropriate for contracted nursing home care on this island or other islands can do often get admitted to the state veterans home. So yeah, it is confusing. The outpatient clinic social workers, it's true that they may not be specialists in the geriatrics and extended care types of programs, but they have been improving over the years in terms of their knowledge and ability to service our frailer types of patients. We also have geriatrics consultation services. So if a patient is, needing a little more of an in-depth dive, the primary care provider can refer patients for a geriatrics consultation. And we have social workers in our geriatrics clinic who can help navigate some of these more specialized support programs.
Great.
Thank you.
There was another question, just making sure that all of the hospices participate in this program. I had a question about POLST. Is there a different new POLST that's inside of the VA? Or do you use the local POLST form?
Amanda, do you want to answer that, or should I try to take a stab at it?
You can try. Yeah.
Okay, so no, there isn't a VA POLST. There is a VA Advanced Directive form that has a little bit more of, like the Kōkua Mau, the commonly used one in our state, has those 3 bullets in terms of if I'm brain dead, if I'm unresponsive, if the burdens outweigh the benefits, then these are my wishes. So the VA Advanced Directive form has a little bit of more nuance to it, and then the veterans can just sign off on every one of those different scenarios. The POLST forms get scanned into the EMR just like any form in an Advanced Directive. The VA, however, has this national initiative that was started in 2017, and it's called Life Supporting Treatment Decision Initiative. So the VA has its very own elaborate template for documenting goals of care conversations, and then related to that to write essentially code orders for life-sustaining treatments, including artificial nutrition and hydration, different life-prolonging treatments, and CPR.
And then, so, the work that we do is to educate people about POLST. So are those things, whatever you called it, the VA form, does EMS know what that is? Are you filling out a POLST after you do that? Just
no, for the community, the person would have to have a POLST.
Oh, good.
So yes, it's another acronym. We call it LSTDI. So
I think you guys get the award for the most acronyms I've ever heard in 1 hour. LSTDI, got it.
Yes. So they are transportable within the VA system. So if the veteran moves from Hawaii to San Francisco, it's going to be there and valid, but it's not something that I guess people could print it and carry it around. I never really explored how that would work, but it's not intended for use.
Oh, so it's
outside
not an
of the
outpatient.
Well, outpatient, as long as they are in a VA facility. So like Michelle can help out, Michelle continue, but like at HPH, we didn't have outpatient code orders. If you put in a DNR code order on a veteran and they collapse in the clinic, it's valid. Okay. The complication is that unlike almost every other state, we don't have our own hospital where, this would be really, really relevant. And to make it interesting, Tripler doesn't honor them. It's a different EMR, and
they don't honor the LSTDI.
They don't even see it. That's my understanding, because it's a separate electronic medical record.
That I have heard before. Okay, so folks will, patients in the community will still have a pulse to put on the fridge and all that, but the other, okay,
That's correct.
good. And in the VA,
And we would like the copy as well.
sure, that makes sense. Do you have, so you have, but you have a place to put it into the EMR?
Yes.
Okay. And will you accept any advance directive, or does it have to be this VA advance directive?
It can be any advance directive. It's going to
Okay.
be scanned in.
Okay, very good. And excellent. So somebody was wondering why we don't have a VA hospital.
That is so above my pay grade, I can tell you.
Yeah. Yeah. Okay, good. So these are all excellent questions. Let's see. Alan says, I think one of the concerns is families don't know what to ask for or know what programs are available for them. The written material is often overwhelming, and a personal touch verbally is helpful for geriatric patients and families. Yep, says the social worker, right? Very good, Alan.
Jeanette, I can answer that, at least coming from the hospice side. So any hospice that anyone reaches out to can have a liaison come out, or a social worker, and talk with them about benefits. You don't need to have a PCP referral to do that. Sometimes we really just get calls in from the community, and whether it's a family member just asking questions, but at least we can go out and talk with them in person pretty much that same day. That's definitely the goal. And hopefully we can help navigate that as well. And if they aren't registered, we try to point them in the direction of how to do that. And it's a free service, so hopefully that can help with that piece as well.
Great, thank you, Erin. That's a good reminder to use the hospices to help figure these things out. I have learned that over the years. They are experts. You are experts at figuring out what's available. Okay. Any other questions out there? I don't see any hands raised, and I don't see any other things in the chat. Our group, you guys have just done a tremendous job at trying to making something that is clearly very complicated more understandable. And in any case, I now have a much better idea about what to ask questions about and what might be available for people. So I really want to thank everybody for the time and effort to come and to create the slides and the handouts, and then to come today to answer these questions. And thank you to the We Honor Veterans program as well